Welcome, everyone. Welcome to the Society of Thoracic Surgeons Intermacs User Group webinar. Today's Wednesday, February 23rd, and it's a little after 1 p.m. Central Time, and we will go ahead and get started. I want to thank everyone for joining today. We looking forward to a fabulous webinar today. Just want to thank everyone for joining. And we have Dr. James Kirklin, the director of the Intermacs Data Warehouse, with us today to help answer some questions. I want to introduce the team. I've introduced Dr. Kirklin, and thank you again for joining Dr. Kirklin. We have Patricia Potter, who's the quality manager at the Intermacs Data Warehouse, Jeannie and Love. We have John Pennington, who's the senior data manager at the Intermacs. He's responsible for all those lovely data sets and research and helps with programming. And then Dr. Ramaraju, who is the director of reporting for Intermacs. So he's responsible for all those great new tools we have and the version upgrades and the programming. So I just want to welcome and thank everyone from UAB for joining today. Any updates that I have, just appreciate everyone joining. I know that we've got some announcements that Rama's going to make regarding the Pedimacs database, and then he's got a few updates regarding the Intermacs dashboard tool. So I'll go through the COVID-19 update. We're still following the COVID-19 rules. Televisits are encouraged. Quality of life surveys may be done over the phone or by mail. If for some reason the follow-up visits, it seems like this is what's really have been affected as the follow-up visit. So if they're getting off course or longer than usual, if they're outside of the visit window, that's okay. Just please enter the last date of the follow-up date visit into the database. And then you have 30 days after the follow-up window due date to enter the data for this exception. So if you have any sites have any questions, you can email myself or Patricia Potter. And I will go ahead and start with Rama. Would you, the director of programming for the Intermacs and Pedimacs databases, would you like to go ahead and start and with any announcements regarding the dashboard?
Sure, definitely. Thanks, Catherine. One big, we're very excited to announce, and so one big announcement is we're working on the Pedimacs dashboard, and our goal is to, we'll have you'll hear more updates in the upcoming months about that. So we'll, similar to the Intermacs, we'll do some committees and then get feedback and then and develop the features. But the first version will be very similar to how the Intermacs dashboard looks, but again having specific displays to Pedimacs. So we'll have that, and then we'll do the beta testing similar to what we did in Intermacs. So we're aiming to complete all of that by AQO meeting in October. So again, we're all very happy and excited to work on this and add that for Pedimacs.
Thank you, Rama. Thanks for all the great work that you and your team are doing.
Sure. And so Catherine, should I talk about the Intermacs, the few features in the Intermacs this quarter?
Yeah, sure. Go ahead.
Let me go ahead and share my screen.
So Rama's working on getting the tools necessary pulled up. Just encourage everyone to try the dashboard. And if you would like training on it or have any questions, you can email us and we'll gladly set up some training for you.
All right. Okay. So in Intermacs this quarter, starting February 1st, we added a new set of features. We looked at the feedback that we got during the AQO meeting and also during the dashboard webinars we did over the last couple of months. And based on that, we added some new features to the dashboard. So this reported events page did not change much. It's the same. It gives a overall counts of all the different patients and then the adverse events reported at the site. so what was so in in the patient characteristics. The biggest change here is we added the site volume filter. So this is based on the volumes until end of 2020. So the end of previous year. So until 2020. So in the year 2020, it's here are all the filters 0 to 10 implants. So if you want to look at just the sites that did only 0 to 10 implants, then we can filter all of the data below based on that, or 11 to 20 implants, 21 to 30, and greater than 30 implants. So for example, if I want to see, I deselect this and I want to see only all the patient characteristics about compare with greater than 30 implants, then my site, I'm right now at Hospital X. Again, that's a randomized hospital. So that hospital is not in that cohort, so I don't see myself. But if I add 0 to 10, then that should show up. Then I can compare that. So this was again one of the top requests, and so we heard many users talk about this. So we went ahead and added the site volume. So this is the first addition, and then next, moving on to the 30-day adverse events. We added several new displays here in the dashboard. So we broke it down into 2 layers. So we changed the navigation to be 2 layers. So in addition to mortality and stroke, we also added readmission, device malfunction, severe device malfunction, and then GI bleed, major infection, and pulmonary infection. So we added all these new displays. They follow the same format as stroke and mortality by showing the average percentages here, and then showing a chart of comparison with Hospital X, my hospital versus Intermacs. So all of that is here. And then, so that is under the 30-day adverse events tab. Now the final addition is under metrics. In addition to, so length of stay was here before, but in addition to length of stay, we also added ICU days. So similar to how we can compare length of stay between my site versus overall Intermacs, we can do that also for ICU days, and also do the benchmarking comparison for ICU days between my site and where all the other sites stand. So that's the gist of all the updates we did in this quarter. Again, like Catherine said, we encourage all of you to use this and then let us know, give us feedback about any new features that you would like to see.
Yeah, thank you. Thank you for that, Rama. I guess while you have this pulled up, Nick, would you like to make an announcement about the survey since we can actually see it on the screen?
Yeah, thanks, Catherine. So I'm Nick Timkovich, and I do a lot of the technology stuff at the data center for Intermacs. And in the top right on the screen, there's a survey button. So thanks to all of you who have already taken this survey. If you haven't, please take a moment to click through this and give us some feedback about it. It's a structured way for us to get your opinions and feedback for how you like it. It only takes a minute or two and really helps us know that the dashboard is working for you. The survey will be taken down on March 1st, so it's not going to persist there forever, but please take a moment and fill this out. It'll be a big help. Thank you.
Thank you. Thank you so much. Let's go ahead and so we can go ahead, just some housekeeping functions. So we will please use the Q&A function for any questions that you may have. We'll answer as many questions as possible. We encourage your feedback, and we really want to hear from you all because you're what makes Intermacs as good as it is. So we will go ahead. There is one update there's a couple of updates I do want to mention before we get started in our Q&A session. The first one is, we went through a version upgrade before the end of 2021. And when we did the updated adverse events, You may have noticed that some hemolysis and right heart failure, some of the zone events have populated onto your patient summary when you log on to the database. And that was to be expected. When we do the version upgrades, we have to map the adverse events. So all those events that you've spent years entering, that they get mapped so that they can follow the kind of grow with the new version, so to speak. So that is, there's no need to have to re-enter or delete any of those older events. They did follow your patient as we go through the new version upgrades and upgraded the adverse events. And John, did I miss anything, or Patricia?
I wouldn't say you missed anything. Thanks, Catherine. I just want to touch on the zones. I've had a couple of questions from users who saw the new right heart failure, hemolysis, hypertension, adverse events that were conditions previously reported at follow-up. Those are mapped over. But if you have any questions about that stuff, I'll put my email address here in chat. Feel free to reach out to me. I'm happy to dig into specific patient scenarios for you or anything like that to help you wrap your head around all these pretty extensive changes that went live back in November.
Yeah, thank you. Thanks, John. And I believe, Patricia, do you have any updates that you would like to discuss or talk about?
No, I don't.
Scenarios. Okay.
I don't updates. Just, I've gotten some questions regarding the new AE. So, if you have questions about your patients, feel free to send them to me. I'm happy to look at them and dive into them with you. So I'll put my email in the chat box as well, and feel free to reach out to me anytime, and we can look at those and see how to best enter them on the new AE forms.
Okay, great. I will, I believe, I know, Patricia, we discussed this, and I know there's been a few questions, and Dr. Kirklin, I'll formally introduce you now. This is Dr. James Kirklin. Like I've been mentioning, he's the director of the Intermacs data warehouse, and he's responsible for he's the creator of the Intermacs database. So thank you again, Dr. Kirklin, for taking time out of your busy schedule to answer some questions today.
Sure, Catherine, my pleasure. There are a lot of very interesting things and updates occurring within Intermacs, including some of these adverse event forms, as well as dashboards you've been hearing about. So yeah, we're happy to try to address any questions.
Sure. I would like to, I believe, I'll pull this up on the training site, but one of the questions Patricia and I had discussed earlier is there's been a few sites that have inquired about if their site physician puts in the notes that the patient has right heart failure. But if you know any more, if you want to elaborate on the details, Patricia, that's fine, and we'll see if get his guidance on how to enter a right heart failure event if it may or may not meet the definition of it, and I'll pull it up in the database.
Great, thank you, Catherine. Yeah, so pretty much, Dr. Kirkland, the questions are about a patient has diagnosis in the physician notes of right heart failure, but they haven't met the early acute right heart failure definition of needing an RVAD or failing to wean from inotropic support.
Yeah, if you can pull that up, that'd be great. So this is the latest. And
yes.
And so you notice that early acute right heart failure, and then there's a definition of that specifically, and they refer to, yes, the need for a temporary or durable device, and then early post-implant, which does not include the device, and then if you check on that, if you expand that, what do you see? The early post-implant right heart failure.
The early post-implant, yes. That is, there you go.
So it is true that you have three basic categories. One is another device, of course, putting in a right-sided temporary durable device. And then the second one is the important one, initiation or continuation of inotropes or vasopressor support or inhaled nitric oxide after 14 days. So it's important to remember that whatever happens in the first 14 days, short of another device, is not counted. So it's after 14 days. And then having to initiate the support within 30 days. So I think with the current definition that you're correct, if you're declaring early post-implant right heart failure, it does require at least inotropes, vasopressors, or inhaled nitric oxide. So I think if your physicians were calling, scroll up just for a moment.
Yes.
And again, look at early acute right heart failure. Click on that, for example, for just a moment.
Yeah, go ahead.
See, there you do need a device. Early acute need for implantation or temporary device before the patient leaves the operating room. So this is an operating room event, having nothing to do with inotropes. So that's early acute. And then post-implant means that the patient has gotten to the intensive care unit. And it does require, if some of you may recall, we had right heart failure as a condition before, and it was kind of complicated. You had a lot of clinical signs and symptoms. And inotropes was not an absolute requirement. So that's how physicians are now looking to perhaps referring back to that prior condition of right heart failure. But we've tried to simplify it according to what has sort of been requested by the FDA and others, that we're declaring a specific event now rather than a condition. And as you can see here, to click into the early post-implant right heart failure, it does require inotropes.
Yes. Okay. So thank you for that guidance, Dr. Kirklin. So basically for the early acute right heart failure, it's if the patient's receiving the need for an RVAD before the patient leaves that OR when they're getting the LVAD implanted.
That's correct.
Okay.
And then early implant is really between 14 and 30 days. Anytime if you require an RVAD, temporary or durable RVAD, anytime after leaving the operating room, or between 14 and 30 days if you require inotropes, vasopressors, or nitric oxide.
Okay, thank you. Thank you for that. It looks like we do have a couple of questions, so I'm going to go ahead and pull those up so everyone can read these. I see actually where we have Sylvia, you raised your hand. Do you want to talk about, you have a question about right heart failure? Oh, you put it back down. Okay. So the first question's from Laura Eckert. The new dashboard functionality is great. Will there be a time in the future where adverse events beyond the 30-day period will be included?
Yeah. So Kathleen, I can answer that.
Okay.
Yes, Laura, that's one of the features we are considering, like where we could select different time periods. So when that feature is available, we'll let you know.
Okay,
But
thanks.
that's currently in the pipeline. Yes.
Okay, great. The next question's from Bill. Patients that have chronically high LDHs, do you enter in as a hemolysis event? They would always trigger in old versions automatically. When entering their hemolysis event, what should you put in for the event date? Okay, so I will pull up the hemolysis form, Dr. Kirklin. So if you see, we have his questions about if patients have chronically high LDHs, are they automatically entered as hemolysis? I would probably, you've got minor and major hemolysis now. The minor is going to be your plasma-free hemoglobin greater than 20 milligrams, or your LDH level greater than 2.5 times the upper limit, so the normal range. So the difference between the minor and major hemolysis is really going to be with major hemolysis, Dr. Kirklin, they have associated clinical signs and symptoms and findings like the hemoglobinuria, the anemia, the elevated liver, bilirubin, and then obviously it affects the pump at some point.
Yeah. So again, hemolysis is challenging because some patients will have an ongoing low level of hemolysis, which is, it fulfills this definition for minor, meaning greater than 2.5 times whatever your upper limits of normal in your institution is for LDH, and then 20 milligrams per deciliter for plasma-free hemoglobin. So I would indicate that the first time you see it. And now, do we have dates on this adverse event, Catherine, a start and stop date, or just an initiation date?
We do have a date of event, yes.
Yeah. So I would put this the first time you see it. If it was continuing over weeks, which occasionally will occur, I just put it once for the first time you see it, and then that's it. For the major event, the same similarly, if you fulfill those criteria, but then in addition have hyperbilirubinemia, pump malfunction, persisting anemia, and it's important there that cannot be explained by another cause. So yeah, so in other words, less than 25, if not explained by chronic illness or the usual post-VAD state. In other words, if the patient had another reason, had a gastrointestinal bleed and had a drop in hematocrit, of course, that would not fulfill the criteria for hemolysis. Even let's say you had a minor hemolysis going on, in which there was an elevated plasma-free hemoglobin or LDH, and now you saw anemia because the patient had a major GI bleed. Well, of course, that would not be a major hemolysis on that basis because the anemia could be explained by another clear factor. But if it's not, then that would be a major hemolysis event. And again, I would indicate the first time that you saw those clinical indicators, that is one of those 4 conditions that you're checking. Once that occurred, then I would pull the trigger and fill out a major hemolysis event.
Okay, thank you. Appreciate that. I'm in the next question. For the right heart failure, the event date we put would be the first day. Her question is, for the right heart failure event date, we put would be the first day after the initial 14 days of the inotropes.
That's correct. Or if you required a temporary RVAD, for example, on day 7, that would qualify as well. But with the exception of devices, then after 14 days.
Okay, thank you. And this one's from Neelam. I have a patient that's had an implant, say on 2/14/2022, and he is still on inotropes for more than 2 weeks. Do we call that RV failure? Wow.
Yes, let's go back to the RV form again, because the short answer is probably. Let's see that.
Yeah, let me get that over here.
Yeah.
Okay.
Okay. Now, yeah, the early post-implant. Now you'll see there, and we all know that inotropes are a bit complicated, but you'll see there that there's no absolute requirement for signs or symptoms of right heart failure, but you just have a patient that's not doing well in general and seems to get a little better with inotropes. And this is one of the imperfections of trying to identify right heart failure, because, for example, let's say you have a pump that's malpositioned and the pump function is not quite as good because you're getting suction events, because the inflow cannula is a little close to the septum, for example, and you're just having some pump issues that you're supplementing with inotropes. Well, you are going to qualify for early post-implant right heart failure because of the need for inotropes. Now, if you felt that that there was a clear indication that had nothing to do with the right ventricle, and you really were requiring this because of because the pump was malfunctioning, or let's just say you had sudden overwhelming sepsis, and so we're hypotensive, we got to use inotropes. You do need to use some judgment there, so that if you think there is a cause totally unrelated to the right ventricle, which is initiating or stimulating the decision for inotropes, well, then I would not fill out a early post-implant right heart failure form. So this does require some clinical judgment. And in this case, if the clinician's taking care of the patient felt, yeah, we're having problems with the right ventricle, a little sluggish, and you're on inotropes, then I would put it. If you had another clear cause, non-RV related, that was requiring inotropes, I would not select this.
Okay, thank you. Okay, our next, you're welcome, Laura. The next question is Intermacs planning to merge with Action, from Beverly? Well, actually, I believe you would be referring to Pedimacs, and as far as I know, as a merger, don't believe. I'll have to take that up to the higher ups, but
Yeah,
not at this point.
Yeah,
Go ahead, Dr. Kirklin.
I'll comment on that for a moment. The answer is no. There are no plans that I know of to merge the two. They each have their independent utility. Pedimacs has great depth and very long-term follow-up of these patients, and other advantages you're all aware of. Action is really great. It's a tremendous opportunity for sort of changing protocols and rapid response and flexibility for group interventions that are thought to be useful. So there is a lot of overlap between the two, but each has their own functionality that both the Action people and the Pedimacs STS people feel are important. So to my knowledge, there's no chance to merge, no opportunity or intention to merge them. What will happen increasingly, we hope, is that there will be ways to develop population of the database in ways that make it less onerous for dual data entry. This is going to take a little bit of time, but that is clearly on our radar screen within the data center for Pedimacs STS to try and work on that option to get things that are more auto-populated within Pedimacs, particularly those things that are overlapping with Action. So more to come on that in the next year or two.
Thank you for that guidance, Dr. Kirkland. The next question is from Ashley. For the new definition of the neurological dysfunction AE, the types 1B and C specify a symptomatic hemorrhage not caused by trauma. How would you classify an SAH that is caused by trauma? And thank you, Ashley. Dr. Kirkland, I'll take us to the neuro event. And this.
Yeah, now this is a good example of some important changes that have occurred in the organization and definition of the adverse events, in part related to an international initiative called ARC, in which they're trying to unify definitions of after major treatments like mechanical circulatory support, so that you'll see here, and let's go to your specific question related to trauma.
Yes. So she is correct. It does specifically say in the updated definition that, it's caused by trauma, or they say specifically not caused by trauma. She's right. It does talk about in the updated, the 1C, but there's no clear-cut guidance for a hemorrhage that is caused by trauma.
Yeah, let's see. open up one as you've opened it up, symptomatic, etc. So those are clearly strokes. Okay. Now, type 2, covert. So that would not be it. And then type 3, not related to injury. Yeah. So, and then, so you're correct. There is no opportunity right now to identify a neurologic event from trauma. And so in that, if it was a traumatic brain injury, as far as I know, we would not be capturing it here. This is, a neurologic event is thought to be a non-trauma related, either stroke related or another type of neurologic dysfunction, type 3. Click on type 3 for a moment. So basically you're talking about either, now you have not actually had a stroke, so you may have had a TIA, you may have had delirium without CNS injury or seizures. And the intent of that is to capture the broad categories of neurologic events that are not strokes. So type 1 basically is an overt stroke. Basically, type 2 is a covert stroke. That is, it shows up on an imaging study. That's type 1. So go to type 2. So those are all the, and then type 2, there's, you have evidence on imaging or pathologic evidence that you've had some type of stroke. One thing that you should notice, let's go back to type 1 for just a moment. Notice that if you have a subdural hematoma, that is included in this category of acute CNS injury, and that's that type 1F. Now, it's, normally we would not consider a subdural hemorrhage a stroke. So when we're talking about in either ischemic or hemorrhagic stroke, that's 1A, 1AH, 1B, not subarachnoid hemorrhage, 1D, those would be the typical situations where we would call that a stroke. Then the other categories are subarachnoid hemorrhage and subdural hemorrhage. Those are typically not stroke. Now, the one thing that, Catherine, go up to the section where it says not trauma related.
Oh, there it is. Right. Not trauma related.
And yeah, where it should,
That would be the 3, the type 3.
yeah, you had language. There is language here that I just missed.
Oh yeah,
that
that
says
is called, yes.
not
I
caused by
don't, let's see. It should be in the type 1s.
I believe
Yeah,
it's
not caused by trauma.
Okay.
1C.
and C.
Okay, and then how about the subdural? Yeah. So this does not exclude trauma. This particular one, and this is one of those things that I think that, thank you for bringing up the trauma. We will have to revisit this a little bit because acute subarachnoid hemorrhage and subdural hemorrhage are the typical situations in which you may have trauma associated. And in one place we've put not caused by trauma for subarachnoid hemorrhage, which, and then another subdural, we have not excluded that. So we will take your question and further explore it, because I think that particularly in these patients, if they were to fall, that we need to have an avenue for inserting something that could be trauma related. And that most commonly, that would be a subdural or a subarachnoid hemorrhage. So thank you for that, and we'll explore that further. But as it stands right now, you could have a trauma-induced subdural hematoma and counted as a 1F.
Okay. Thank you for that. And I'll put it on the agenda for the next call so we can discuss it.
Right.
The task force. And thank you for bringing that to our attention, Ashley. Sylvia has a question. If the patient has an ECMO placed during the LVAD implant, but the ECMO has an oxygenator, is this considered an RVAD? Dash acute heart failure question mark. Well,
Yeah, let's go to the implant. And we have revised the forms so it gives you the opportunity to indicate those things which occur, perioperatively in the operating room.
yes, and I believe Sylvia, the road you're leading down is the right heart failure definition, because that acute or the early acute, I believe, does have words regarding ECMO. But here is your ECMO, the oxygenation. Is that where you wanted to go, Dr. Kirklin?
Yes.
So if you do click that.
Yeah. So this, what you're referring to is an oxygenator to an RVAD placed in the operating room. Is that correct?
Yes,
Okay.
that is.
So and I would say that is ECMO. Yes. If you, well, let me just, so you're literally talking about an RVAD. So say, for example, right atrium to the pulmonary artery with an oxygenator. Is that correct?
Correct.
Yeah, if that's the case, then I would not include that as ECMO. I would include that as an RVAD.
Okay, so
And
we'll have to go ahead.
And the reason is that the distinction is if you were putting an oxygenator in the circuit that led to the arterial outflow, that is ECMO. So in other words, if you have venous inflow and then an oxygenator and the outflow is going to the aorta or a systemic artery, that is ECMO. There are some people that, for example, treat pulmonary hypertension with an oxygenator to get high oxygen concentrations into the pulmonary artery to improve RV function. Let's say you had an RVAD and you had a pulmonary artery catheter or something, you had very high pressure, some would add an oxygenator there. If you do that, then even if it ended up improving your overall oxygenation, if the outflow from the ECMO circuit is not going to a systemic artery of the aorta, then I would not call it ECMO. So I just want to make sure I'm making myself clear there. So if it's purely an RVAD circuit, that is right atrium or inferior vena cava, superior vena cava to the pulmonary artery in which you insert in that circuit an oxygenator, then I would still call that RVAD support.
Okay. I will actually probably follow up with you in regards to that, just so that Patricia and I'll have clarification of exactly the scenario. So when sites ask us.
Sure.
So, and I believe, Sylvia, you were asking because Dr. Kirkland, the early acute right heart failure, this part of the right heart failure definition does say including ECMO, and I'm assuming it's because of what you just discussed.
Yes. So if you have a temporary durable RVAD, including ECMO, concomitant with LVAD implant, then we're going to call that early acute right heart failure. That's correct. Now, that's to be distinguished. Let's just say you put in an LVAD and the patient has severe lung injury from whatever reason, and you cannot oxygenate. So as you know, there is an ability, of course, to add ECMO in that situation, but with outflow to a systemic artery or aorta, that's ECMO plus an LVAD. But in the right-sided circuit, as indicated here, it would be early acute right heart failure.
Okay. Thank you. And Sylvia, I believe that answers your question. The next question is, if an AE occurs and resolves during the same hospital admission and it recurs, such as infection, do you enter another AE or not? I was thinking not unless a new bug or bacteria occurs. I'm happy to take this one, and you can add or correct me if you want, Dr. Kirkland, but usually what Patricia and I usually educate sites is you're correct, Barbara. If it's like a recurrent infection, you would not enter it unless you're right. If it's a new bug or bacteria, if it's chronic and ongoing.
I agree.
And I just wanted to add to that, or if there was a change in therapy.
Yeah, there you go. Absolutely. Okay, thanks. Curtis asked, is there a timeline to set up a Pedimacs reporting dashboard similar to what is presently available for Intermacs? And Curtis, Rama mentioned that earlier on this webinar. There is going to be a Pedimacs dashboard, and it will launch at AQO. So I believe that's in October of 2022. So yes, Pedimacs will be getting the dashboard.
Yeah, I want to just comment upon that further, because that's it was always our intent once Intermacs dashboard was up and running, and in fact we can take advantage of users' input into the Intermacs to help us design the Pedimacs. We think it'll be very valuable, and as you know, in some ways it's going to be a little bit more complicated, because there is a much greater variety of devices within Pedimacs, including potential for temporary devices. And so it will be a challenge to get the type of dashboard which will be really useful to all of you in the pediatric domain. So we will be enlisting the help of some experts in pediatric mechanical support to help guide us in the first rollout of that dashboard. As you know, in Intermacs, it's a little more straightforward. We're only dealing with durable devices. So, but I think you'll find it really amazingly useful, just like the one in Intermacs. So we're looking forward to that.
Okay, thank you. Yeah, we're very excited about it. Very. The next question is from Eunice. She's asking for hemodynamics such as echo. It says data may be entered that was collected, performed from the last time the patient was seen for follow-up to the current visit date. Her question is, so does the echo only need to be performed before the 3-month visit is utilized, and it can be used even if outside the follow-up window?
Catherine, I can take that for you. So
Thank you.
Eunice, yes. So no, it doesn't only apply to the 3-month follow-up. It's for all subsequent follow-ups after that. And any echoes that are done since the last follow-up visit inside the follow-up window can be used for that follow-up. So if you're working on a 6-month follow-up, you can use any echoes after 3-month follow-up that falls within the window of the 6-month follow-up.
Okay, thank you for that, Patricia.
Yeah, absolutely.
And Sylvia, Sylvia, we went back to the right heart failure form. I saw where you were going. And Colleen, how can I get dashboard training? Well, Colleen, if you contact Patricia or myself, and we can get you set up with some dashboard training. And Cindy has a question, will it be possible to select the date ranges for the dashboards? Currently, that isn't an option. Thank you. I think Rama may have already gone, but does the date ranges?
Yeah, well, now that will be just a couple of comments about the dashboards. We will be evolving a little bit more of a query opportunity to expand your dashboard from what is it now, quarterly, 3 quarters? Yeah.
Last 4 quarters.
Quarters, yeah. So we will eventually be expanding that so that you could select, for example, I want the last 3 months, last 3 years, last 3 6-month intervals. That will be on subsequent rollouts as soon as we understand better exactly what the desire of the overall VAD community is, about what would be useful. So yes, that will be coming in the future, and will be guided a little bit by, as we meet with the task force and other stakeholders when we roll out subsequent versions, what's most important to you, adding more things in the menu, expanding the time frame options, etc. So, but yes, this will definitely be coming in the future.
And I would reiterate here, this is the perfect example of why we would love you to take that survey that Nick talked about. This is where you can give us that feedback.
Yeah, thanks, John.
Thank you. Neelam has a question. If the patient's device is turned off for withdrawal of support and the patient dies, our physicians have a problem filling the explant form. They feel we should just fill out the death form because explant refers to taking the device out of the body, like in heart transplant or a new device. Advice, please. Well,
Yeah, so
currently, go ahead.
Let's go to that form. There's a form about explant and so on. So let's look at that.
We're just gonna, I gotta put in a date or it'll, Okay. So she's talking about explanting for no new device because it's withdrawal of support, correct?
Now, check all that applies. So remember that there is this term in here called decommissioning. So maybe you have to look at explant reason or explant.
Turned off.
Yeah, there you go.
There you go.
So oh yeah. So see, you can turn this, you can check on this turned off decommissioned, which is, as you know, is getting actually more and more common because of the major insult to the major risk, if you will, in the magnitude of the operation of explant. There are increasingly centers that are decommissioning the device, turning it off, cutting the drive line below the skin in a way that hopefully will prevent infection, and then, for example, plugging the outflow graft. So that's decommissioning the device. And the reason could be withdrawal of support. And then, of course, then you also would fill out a death form. Whatever the cause of death was. So I think it's all consistent. The patient was dying anyway, so we turned off the device. Okay, as long as the patient was alive, you decommission the device, withdrew support, check that box, and then you fill out a death form.
Correct. So so Neelam, you have to choose, when you choose decommissioned, and then actually when you do choose it, and Patricia, you can confirm this, once this is chosen and you're going to submit this form, they're going to want a device, but once you do this, you should get the 1 year post-fixation form, correct?
That's absolutely right. Yeah. So if you complete the explant form for a device that has been decommissioned, turned off, or withdrawal of support, a 1 year post-cessation form will generate, and you can capture the death there. So if it was turned off and the patient, passed 3 days later, you can capture that on the 1 year post-cessation.
Right. Code is explant death, or it requires the 1 year follow-up. You're correct. Or usually if it is, just to kind of tidy that up, I see where you're like, we're talking about coding as, if it is the device is turned off, decommissioned for withdrawal of support, and we know that death is imminent, you would choose turned off. And then if the patient, you would choose then withdrawal of support until if the patient hasn't expired, like Patricia said, if it's like 3 days later. And then you would complete that 1 year post-cessation mechanical support follow-up.
Yeah, inform me about this, Catherine and Patricia. So if I were a center filling out a form and a patient died, I don't know, 6 hours after withdrawal support, and you just turned off the device because you knew the patient was dying, which I think in part is the spirit of this question, I would just call this a death during support. So I would include, check off the withdrawal of support, but now can you also then add a death form here?
Once they validate and submit this, and then they have to go to the death form.
Right.
Right.
And they could do that, correct? You wouldn't have to necessarily go to the 1-year follow-up form. If they elected, they could just go to a death form.
Well, yes, they could go directly to the death form. You are correct. However, a 1-year post cessation of mechanical support form will automatically generate because of the reasons Patricia had read. That 1 year, it's not like a typical 1-year follow-up. It's just, we're just finding out after 1 year without any implants in, hey, is the patient, were they transplanted or are they still alive?
Yeah, I think, and I might be wrong, so you can correct me in the chat box. I would make the argument that I don't care about the 1 year, that I wouldn't be concerned about the 1-year follow-up form if I filled out a death form. So if I fill out a death form, now forget the 1-year follow-up. If I chose now withdrawal support and then I clicked on a death form, tell me what that would show us what that would look like.
The 1 year, the death form?
Yeah, just a death form.
This is the death form.
Okay.
Then
So what if
you'd enter the date.
Yeah.
And then you have these questions, device functioning normally, postmortem, and then your primary cause of death.
Right. And so what I'm thinking is that if you did these things, then if you thought this death was intimately related to the patient was dying and you turned off the device. Now, if you decommission the device as the patient is not doing well, but limping along, well, then that to me would fall into the 1 year post implant. Tell us what happened during that first year and the patient died. Let's say it was 5 days later or whatever. But if it was very closely associated, the patient's dying, we've informed the family, and they don't want things to linger. So please turn off the device, even though, the EKG is not yet flat. And then within hours, the patient dies. So I would include that as a death, if you will, during support, or meaning I would not fill out a 1 year form. I would fill out the decommission.
Okay.
The reason for is withdrawal support, and fill out the death form. Okay.
And we have many sites do it that way. And Patricia, I believe there in John too, there's some, I know we handle this at UAB when I know there's internal checks for this, I believe. If there's a 1 year follow-up, I don't know, John, if you still print those out, maybe that could have been years ago.
Yeah, go ahead, John. You can speak to that.
Looking for the patients that have passed that 1 year time point but haven't got a completed post cessation form.
No, let's talk about specifically those patients who died within 48 hours of let's say they decommission a device, so they're no longer on support. That's explant form. And then you put withdrawal support, but then they die very shortly after that, never mind, and they fill out a death form. And that death date is actually after, let's say it's 1 day later, after the withdrawal support, decommissioning the device. So the question is that a death during support?
Well,
so I would say yes. I would say yes.
Okay.
And so, John, this might not be in your domain right now, but for example, if it came up with, if Ryan and the statisticians were saying, okay, let's look at the deaths during support, we're going to censor you, at device explant, right? That's our usual. But if somebody exactly like ECMO, in other circumstances, if you have somebody on ECMO and you withdraw ECMO support and they die within X number of hours, we call that a death on ECMO. And I would treat this the same. So if you thought the patient was in the process of dying and you stopped support, whether it be ECMO or a durable device, and turned it off, decommissioned it, and the patient died within 48 hours, I would call that a death during MCS support.
I'd I'd have to look at our analytics build, but I actually get a feeling that we programmed this as death trumps all there, and that this patient, because they've reached 2 endpoints, being cessation and death, would be marked as dead.
In other words, that patient would have been called an explant.
No, they'd have been called an explant because of cessation of support, but they would have also been called dead. And so, since those endpoints are mutually exclusive, I believe the bill would go in there and mark them as just overall dead.
Yeah, so that's well, maybe it would. If it would, that's great. But if they ended up being censored at the time of explant, which was 12 hours before they actually, let's say 24 hours before they actually died, there is a chance that they could be censored because of explant, and that death would be missed because, as you say, they're mutually exclusive. So this brings up a good point that that I will take back to Ryan and just discuss it to see if we have the situation which you have a death listed, but an explant just before it. What do you do in our analytics? And I know that's a little bit beyond this question, but it brings up a very good point of if a death occurs immediately or promptly or soon after an explant, a decommissioning, whether that's should be called a death during support. So we'll check on that.
Okay, thank you, Dr. Kirklin. I know we're about out of time and we have a few more questions. Carol, do we need to just end it, or?
No, you can go ahead and take it as long as everybody's able to stay on, or whomever could stay on to help answer the questions is available. I think it's fine to keep going.
Okay, Dr. Kirkland, do you have a few more minutes? We'll shut it down after these questions, but
Sure.
Neelam's, she's the one that originally asked the question. She said if the reason was a neuro event, but there was a withdrawal of support, and if we check the neuro event, we can't check that the patient died from it, then we do have to fill out the death form. I'm confused at that, but
yeah.
she's saying neuro event, withdrawal support.
Oh, yeah. So I would say the exact same thing. In other words, if you have a neuro event, you withdraw support, and now you're wondering, well, do I fill out a death form because actually you withdrew support first, but stroke caused the death? And I would say absolutely. If it looked like that, it was a week later, well, then no, then that becomes a death during that first year. And we also collect a cause there, don't we? Or no? If you died during that 1 year follow-up, do we ask for a cause of death?
Yes, we do.
Yeah. So then I would put that stroke there also, if it was, an extended period of time. But if it was in a day or two, and as I said before, we'll discuss that. But then I would call that a death on support caused by a stroke.
Okay, thank you. And then we'll scroll down because Louisa says, I just had this occur. I had a patient decommission their VAD and they died within hours. I filled out both the explant form and the death form on the adverse event. So good. And I didn't get the 1 year post cessation form. They had withdrawal of support, had gone home on hospice and died at home. Well, I thought it did generate if they choose decommission. Maybe I believe that's listed for one of the reasons.
I think maybe she didn't get it because she completed the death form.
Oh, gotcha. There you go.
Yeah.
Yeah.
Okay.
Right. If the patient went home, is this the patient went home on hospice and died at home?
Yes.
Yeah. Well, then, and under that circumstances, I would elect to fill out the 1 year follow-up form. I would not fill out a death form during support. I would pull up then in that case, the 1 year follow-up form will pull up, correct? If you don't fill out a death form, and then I would fill out the death form there related to the 1 year follow-up form.
Okay.
And to circle back to, sir, if a patient is explanted for reasons of no new device or for decommissioning, if they have a death within the 1 year time point, we mark them as dead for research. If they have a death form completed 1 year or greater, we mark them as recovered.
Right. Okay. I mean, are you asking or informing us?
No, I'm filling in. I went and looked at the build code to see how we're handling the analytics.
I see.
Okay. Thanks,
Okay.
John. And then Sheena's asking, can we have these scenarios documented to review later? We have the hospice withdrawal support situations frequently. Patients pass with an hour of withdrawal support, and this has always been a guess on how to capture appropriately. Thanks. Sheena, yes, these are actually, the webinars are actually recorded and posted on the STS website. And so I can send you the link of how you can get this you can access this. I'll be posted later in the week.
I was going to say, Catherine, I can put it in the chat box, the link to the YouTube webinars.
Okay, great. Thanks, Patricia. And then Sylvia's asking, does the patient's Intermacs case end when the patient is no longer having a device? Well, technically it ends when they reach an endpoint, which would be what, so yeah, I mean, if the device is maybe functioning device would be better, because I know if the device is decommissioned, so it's turned off and not functioning, then yes. So it ends when there's not a device. And I don't know, Dr. Kirkland, do you want to add to that, or misspoke?
Yeah, so let's reframe the question again. The device is in place but not working?
No, she's just asking question. Does the patient's Intermacs case end when the patient is no longer having a device? So if the patient doesn't have a device, that's the end of the patient's care in Intermacs.
Well, yes, with a single exception. It depends. If it's transplanted, then yes. If the patient dies right at that point, yes. But if the patient is off a device and alive, then the end of Intermacs really ends 1 year later. Would you agree with that, Catherine? In other words,
Yeah, go. I'm sorry.
Will they also get a form that pops up at that year interval, or when will that form come to their attention, the 1 year form?
That 1 year form will pop up at explant no device, right, Patricia? Is it recovery and decommissioned?
Yes, it will generate as soon as they enter one of those 3 options on the explant form, and they can fill it out. If the patient, passes or is transplanted within that 1 year, they can fill it out at that time. They don't have to wait the 1 year, but if they are still alive and not transplanted, due to recovery, they can fill it out at that 1 year mark. That's correct.
Okay, thanks. Thank you. Dia asks or is stating, we had this occur at our site. 2 patients were passing and we stopped support. They died shortly after. We followed the directions to complete the cessation of support, and they showed up as alive on our survival metrics. I discussed this with Ryan last fall. He updated the analytics to accommodate it for the future. So it looks like probably, yeah, it would be good to talk to Ryan about this form, Dr. Kirkland.
Yeah, because it literally is this: when you die after the device is declared decommissioned or explanted, what do you do? And so we will discuss that. But I think what we'll do is we're going to discuss a time period within which, if you die, we're going to include that. We're going to label that as death on support.
Okay, thanks.
I personally would suggest 48 hours.
Okay, that's good to know. Neelam, so if the patient dies in the hospital, then we should fill out the death form. And if the patient is discharged, then we should fill out only the explant form. No, we're going to work on this, Neelam. But if the patient dies, whether they're in the hospital or at home, then a death form needs to be completed.
Right.
We'll provide guidance.
Yeah, I think.
Go ahead, Patricia.
Oh, I was just going to say, and regardless, the explant form still needs to be completed if it is decommissioned.
Yes.
And then whether you retrieve the death on the 1-year follow-up form, or that you go straight to the death form, we are going to provide some guidance on. And because we will discuss this internally with our statisticians and John. And I think basically the spirit of the question is, if the patient was already dying and you just took out the device for either humanitarian reasons or others, then that's a death on support. If a patient was just lingering and you took out or stopped the device, then that's a death following explant. And so there's a lot of room for discussion about how to define those periods. But as I said, I would suggest 2 days, 24 hours, or 48 hours. But we'll clarify that and get back to all of you.
Okay, thank you. And then Dia, can you provide updated documentation on when to use the death form in the cessation of support situation? Yes, Dia, we will work on that and we will provide it to sites. And then Louisa just had a couple of comments. And then the last question, would it be possible to label death within 48 hours of decommission instead of while on support? Because they get lumped in the same group as patients who die while the pump is running.
Yes, that's a good suggestion. I think we should, we'll consider that. I think to be fair, we are going to analyze them the same. That if you die while the pump is running, and if you elect to turn off the pump and die within, we'll say 48 hours, that's a death. That from a research point of view and from an analytic point of view, and if you're center specific information, that will be a death on support. Now, it's not literally on support, but as we know, if there would be a potential for anybody to say, well, look, he's dying. Well, let's go ahead and turn off the device. Dies 5 minutes later. Well, that wasn't actually death when the pump was running. So that would violate the spirit of death on support. So, but we'll clarify all of this in a nice, neat way and discuss even the possibility of saying death within 48 hours afterwards, if that would be helpful to all of you as you fill out your form. So we'll get back to you on that.
Okay, well, thank you. Dr. Kirklin, thank you. Yay for your guidance today. Thank you for taking the time to be here. Definitely, I've learned some things, and we'll definitely work on that, the cessation form, and provide the parameters for that. And we'll definitely get back to everyone and let everyone know. So thank you. Thanks everyone for joining today. I appreciate it. If you have any questions or if you're interested in the dashboard training, please email Patricia and I, and we can get that set up for you.
Right.
And so I hope everyone has a great day. Thank you.
Thanks, everybody. Good job, Catherine. Bye.
Thank
Thank you, Dr. Kirkland. Bye.